Welcome to the Homegrown Heart Podcast, brought to you every Friday morning at 7 a.m. Mountain Standard Time with your host, Dr. Amanda Ryan, DO, MBA, interventional cardiologist, and a recognized expert in her field. This week's topic, COVID and clots. Please help me welcome our host, Dr. Amanda Ryan.
Good morning, Carlsbad, Eddy County, and all my listeners near and far. It's Dr. Amanda Ryan, your friendly interventional cardiologist, and we're continuing to roll on weekly with so many exciting topics. Closing out February Heart Health Month. We ended up canceling the walk last week. We're going to reschedule that. It was about 14 to 22 degrees here in Carlsbad, and the people we did have signed up were like, we're all for walking, but that's a little cold. Especially when, if you waited till later in the day, it might have been 60, by the way. This is just the craziest weather. I think on Tuesday, by the way, I've been on call this week, I think 5 days, we've had 4 emergency heart attacks, one each day. Crazy. I don't know if the stress is high. I don't know if people are watching too much news or what's going on. But yes, in all seriousness, it has been a crazy weekend. Praise God for a lot of good outcomes and my amazing team, both at Advanced Heart and Vascular Center of New Mexico, at Advanced Ambulatory Surgery Center of Carlsbad, New Mexico, at Partners in Heart Health, our foundation, and then at our local hospital. Our cath lab team is top notch, and I just respect what all of us do. Okay, I just had a minute to think about so many different things that have occurred during February, and I think we've really reached a lot of our goal, which was increasing awareness. Also making some really good partnerships. Partnerships are part of how we're really going, again, whether it's the patient we're talking about, whether it's other businesses, whether it's other physicians, in my instance, whether it's the community, whether it's other corporations and healthcare entities. Partnerships are the way we're going to get stuff accomplished. We definitely can't have that, forgive this if you don't know exactly what this means, but we can't have a crabs in a bucket mentality. We can't see somebody achieving something. I saw this for the former corporation I worked with. Instead of collaboration within hospitals in the area, it would be one CEO seemed to be making money and getting some kind of praise for, providing good care and making money in GI, let's call it gastroenterology. So then hospital B, part of the same conglomerate, goes and just tries to get a GI doctor, even sees if they can steal that one, for example, and get them to come over to them. And I'm like, don't we all work for the same company? Isn't the goal all the same here? Aren't we trying to serve the patients of our area as best we can? Again, roll it back to naive me. That's 15 years ago me. That's not today me. Today me knows that sometimes in any business, and healthcare is no stranger, that bottom dollar is the goal of a lot of entities. We've got to shift that. We've got to remember, and again, it's complicated. Complicated to be a capitalist society about everything but healthcare and then say, oh, no, we shouldn't. We should be socialist about healthcare, capitalist about everything else. It doesn't work either, by the way, because unfortunately then best and brightest ideas are not going to come out. Again, I had a patient, we were discussing a defibrillator the other day, and they were like, oh, it's kind of large. Now large, it's about this size, goes right under your skin. I know it's hard to believe with my youthful self that I'm old enough to remember when defibrillators were like a gas can in someone's abdomen. And they had drive lines in their groin, literally, that drove in, and then it was about this size. You could see it looked like a little gas can pack stuck in someone's abdomen. It is one of the smallest, most high-energy devices in the world at this point. And if there wasn't some financial incentive for large companies to invest in research, we wouldn't be where we are with them. And so these life-saving, amazing devices And that's just one area of cardiology, then cardiothoracic surgery, that have expanded with devices. We're not going to expand with those unless we continue to pour money into research, and that costs money. So just when we're looking at about, how we're going to, and that kind of segues into what I was going to talk about today, which are DVTs and PEs. Those are deep vein thrombosis and pulmonary emboli. Those are blood clots. Ooh, talk about complex. The clotting cascade in humans has like 100 factors. You can have over or under production of many different proteins and factors along the way of that clotting cascade. That doesn't matter. Some of them you're born with, some of them are inherited, some of them just happened as a mutation at birth, some of them you acquire at some point in life. There's been a lot of controversy in the last few years about the COVID vaccine and COVID itself. I can tell you as a physician and team that accepted and treated patients with large blood clots during COVID and after, that both COVID itself markedly increased the risk of clots, and the different COVID vaccines probably slightly increased the risk as well. However, that can be seen with other viruses too, but it was the overall inflammatory condition that came with severe COVID. There's a number called a D-dimer that we check on people. I always tell people a D-dimer has a very good negative predictive value. That means if it's low, you don't have a blood clot. If it's high, you might, but high is like a whole number of 1 or 2, by the way. So you could have a blood clot. It tells us we need to go on with testing, because it can also be high with just different infections or after you had a major surgery or like other things. So just having an elevated D-dimer doesn't automatically equal a blood clot. Will often lead to a CTA or a pulmonary angiogram, ultrasounds of the legs, really trying to figure out if you have a clot and if so, where. But the numbers of some people with COVID, the D-dimers would be 100, 200, like just crazy numbers. To the point where we realized with these really sick people, we had them on full dose blood thinners trying to protect them from blood clots when they were in ICUs across America, when they didn't even have a blood clot. And that seems kind of crazy, honestly. But again, we had people dying right and left. We didn't have time to really study it as best we could. And so we were doing anything we could to try to prevent these blood clots, which were so massive, many people weren't surviving them. But if they did survive them, we were able to try to help people. We have so many different amazing devices. It used to be start a patient on blood thinner and pray. That's kind of what we did if you had a big blood clot. Things have advanced to this whole realm of called CDT, or catheter-directed thrombolytics. What does that mean? That means that, again, well, let me actually reverse. We started on blood thinners. There's one particularly powerful blood thinner called TPA, tissue plasminogen activator. Okay, TPA is a very powerful clot buster drug that we can give somebody that has a stroke, a certain kind of stroke, a life-threatening blood clot, or a massive heart attack, not at a facility that we can take them directly to the cardiac catheterization lab. These medicines do work oftentimes, but they have a very high bleeding risk and some very clear-cut contraindications for you can't use them in certain instances. But unfortunately, if we give it through an IV, it goes to your whole body, right? Then we might clear up your blood clot, but all of a sudden you're bleeding into your kidneys, your bladder's bleeding, you've got you've got a big hematoma, we call it, a blood collection in your leg. You're bleeding into your lungs. You can have a head bleed from TPA. So there's all these different things that can occur. So we've realized, hey, maybe we can give this quote-unquote thrombolytic drug through a catheter directly to a blood clot, and it can start to break it up. And because that's really what's important. Your body immediately throws thrombin there and other activating factors. Platelets get attracted and the clot just gets bigger and more formed up. So how can we try to break that clot up? So that you don't have long-term problems from either a blood clot in your leg or a blood clot in your lungs. So one device that we have that I've used a lot is called an EKOS, E-K-O-S. This is a very neat device that delivers ultrasound waves at the same time that it drips this thrombolytic agent directly to the blood clot that we're treating, whether it be in our lungs or our legs. So that markedly improves outcomes with decreasing the risk of bleeding that comes with giving systemic or whole body thrombolytics. So that's been around several years. We've used a lot and it's pretty good. But honestly, some of these blood clots that we were seeing in COVID, it really wasn't being that effective. It also requires 24 hours to drip the medicine in, an ICU with trained staff, and ICU beds with trained staff handling a special device. They were hard to come by during COVID. They're hard to come by anytime. Again, healthcare in America is in crisis, and the biggest crisis is staffing. We've got to continue to think of ways to fix that. We've made I've mentioned before that Methodist in Houston, I believe, has started at healthcare high school. As crazy as that might sound, if we've got young people that know they're interested at that phase, sometimes fast tracking these kids that's these young people, this is somewhat what we need to do. We need to find ways that they can still get all of the knowledge, but fast tracking is an option. Another option, by the way, on that is having, nursing school. Traditionally, it's about 2 years worth of prerequisites and 2 years in nursing school just to get that initial RN degree. We've got a lot of working parents, people that really do want to go to school or interested in nursing and other allied health fields, but unfortunately don't have 2 years to commit where they don't work at all, which is really pretty much what the requirement calls for. So maybe shifting that to where, again, there are national standards. They have to meet them. We do not want to graduate anyone with less competency. But maybe we can make a 3-year program. Maybe we can do some nights or weekends. We really have to learn to, quote unquote, think outside the box in all these areas so that, there's talk about new hospitals in our area, and that's exciting, and there's options, and we're talking about stuff, and it's going to take several years. I'm going to say it's in the 5 to 10 year range. And again, our beautiful facility and surgical center was 5 years from idea to opening. It takes a while. However, you can make the shiniest new building with the most beautiful state-of-the-art equipment. You've got to have qualified, trained staff. Our staff have spent years in training, years to get to this point. We've lost a lot of valuable staff along the way. I think I'm a good leader. And when I reflect on why have we lost some of the staff we have lost, people I really did think were, in it for the long haul, really believed and bought into the vision. And I continue to believe that. Sometimes it was interpersonal conflicts, sometimes it was personal lives, but we're trying to be the doers and the leaders and the people that develop this program that's a little outside of big healthcare in a rural area. And guess what? It's not easy. While continuing to meet the daily needs of our patients, which honestly, we get complaints every day from our patients. We also get kudos and we had a great experience comments, but we also get the it's unacceptable to wait an hour comments. And we're sorry you have to wait an hour, but I promise we are out there doing the very best that we can to change rural cardiovascular healthcare. And again, it's not easy. It is taking so much of what each of us have on a personal and professional level. By the way, there's nothing else I'd rather be doing. I'm not going anywhere. And I'm extremely proud and grateful for the opportunity to serve everyone in this area in the way that we are. I'm just trying to get people to realize that when you go to immediate criticism, again, I think I've said this before, but I've been on the OBGYN table getting a yearly examination and said OBGYN has to go deliver a baby. I could be like, I'm a doctor and I can't wait, and I got an office full of patients, and that's disrespectful, and she has to go deliver a baby. And yes, Dr. Amanda Ryan, in that instance, what your OBGYN needs to go do is more important than you. Sometimes in life and in our society in general, my husband and I sometimes joke, and some of my staff, we got first world problems. being upset because you have to wait an hour to, go on a medical mission trip somewhere and see people walk 50 miles to get literally 3 and 4 days sometimes to be seen by a medical student that's coming to a free clinic with their child's tonsillar abscess that's about ready to rupture. I mean, you really do realize sometimes that the things we're complaining about, and you'd be like, well, I'm not in Guatemala, I'm in the United States. Okay, I realize that. But your frustration about waiting for appointments or length of time, or a medication refill that didn't get fixed immediately. I mean, sometimes you've got to take a step back and realize you are important, you are valued, but you are not the only person that we are serving. So these blood clots during COVID, again, got more and more difficult to treat. Traditional TPA, heparin, warfarin, and then these newer drugs like Eliquis and Xarelto that are out on the market for treating blood clots, they weren't working as well as what they had in the past. So then came the development of some other kind of devices. Again, I'm not here representing any specific company or devices. I'm just here to express what we can do with some of these amazing equipment. There's a device called Inari. There's one called Penumbra. These are devices that will literally go in the cardiac catheterization lab and again, suck clot out of your legs, suck clot out of your lungs, and really allow full restoration of blood flow immediately. And I'll show a few pictures with my wonderful producer, Danny Fletcher, so that he can actually show you what these blood clots look like. So let's definitely do that. I know sometimes, Danny, I say I'll send you those and I get so busy I forget. So I will be doing that. I'll be doing my part here. But I want you to see what some of these blood clots that pull out are. It is just nothing short of amazing to really be able to pull some of these blood clots out of people's lungs and their legs. What are some of the symptoms of a blood clot in your leg? Your leg's tender, especially one leg. So unilateral one leg, it's tender, it's swollen, it can be warm to touch, it can be red, or can be any discoloration, but definitely a one leg very swollen. Now again, sometimes that can be lymphedema too. That can be problems with your veins. That can be heart stuff. That can be liver issues. There's other things it can be. But we have to be suspicious of a blood clot with one swollen, painful, hard feeling. If you squeeze your calf and that creates a lot of pain, that's called a positive Homan sign for a blood clot. That's a DVT again. What are some of the symptoms of that blood clot? Again, we worry the most about blood clots in your legs because if you don't treat the very large ones, by the way, you don't need catheter-directed thrombolytics for every small blood clot in your legs or your lungs. But the larger ones, they obstruct flow basically, and then you can end up with chronic leg swelling, ending up with venous ulcers, which is a huge problem and significant morbidity and mortality in our elderly people. So trying to prevent those things from happening are why we want to try to apply some of this technology to current blood issues with blood clots. Now, that blood clot moving to your lungs is the biggest fear. Okay, so, sorry, I'm on call, so I have to look and make sure that there's nobody's calling me for work from the hospital. Okay, so blood clots in the legs. Sorry, back, I gotta get my thoughts back. Blood clots in the legs that move to our lungs. That's our biggest concern. So that's a DVT becoming a PE or a pulmonary embolism. Most clots in the legs, in the lungs come from the legs. Sharp chest pain, worse with breathing, on one side or underneath your breastbone. Can be dull, aching, or burning, can also be sharp or stabbing. You're short of breath, you just can't take a deep breath. All those things can be signs that you have a blood clot. You could also have a sudden cough. You'd be coughing up blood, your heart rate could get fast, that's tachycardia. Your blood pressure could get low. You could get clammy skin, sweating, diaphoretic. You could get bluish skin. You could feel dizzy or faint even, or you could feel overwhelming feeling of doom and anxiety. If you have any of those symptoms or a group of those symptoms, you need to get checked out for a blood clot that's moved to your lungs. You've got to call 911, get to the nearest emergency department. What are the biggest risks for blood clots in our legs or lungs? If we've been immobile for a long time, if we're morbidly obese and we just don't move around much, if we have had surgery or trauma, pregnancy, current or recent, if we're taking oral contraceptive pills, estrogen, testosterone, a cancer, a malignancy, we have hereditary factors that make it at increased risk. We've had a very long medical illness recently, any kind of drug abuse, and then some of these different viral illnesses, including COVID. These are definite, kind of higher risk factors. We have to see that. There's a lot of beautiful women that I've treated in the last 10 years that have went for what's called a mommy makeover. They're getting breast and abdominal plasties done together. That is a very large plastic surgery procedure. And again, one of my great friends, Dr. John Tedesco in Oklahoma City, he doesn't like to do both of them together because exactly of the risk of blood clot he feels is a little bit high. But for cost purposes and time off work purposes and just societal pressures on women, which would be that'll be a whole podcast of its own. Sometimes women really choose that's their best option. Some of the most serious cases that I have treated here of blood clots have included women that were after that procedure that just passed out. They got dizzy, lightheaded, overall just did not feel well. At first, by the way, most of those women were like, oh, you're just not used to the pain medicines. You need to walk more. You need to do this. You need to do that. Until they collapsed in a life-threatening situation with blood clots that they were lucky to survive. So if you have any of these symptoms after a major surgery, trauma, or otherwise, passing out in a post-op patient, I tell people, is a blood clot in your lungs until proven otherwise. Now, could it be your blood pressure is getting low, pain meds, your reaction to pain, all those other things? Yes, it could. But you're not going to die from those things, and you can absolutely die from a blood clot that's not treated. So if you only get one thing from today's session, that's what I want you to get from it. Again, I've touched on lots of different treatment options. There are continuously expanding options for how to treat. It's also what other doctors should be involved. Sometimes a hematologist referral for a full blood panel is appropriate to really check and see, why did you get this blood clot if you didn't have any of these traditional risk factors? You didn't have a long plane ride, a 15-hour car ride that you never got out of the car and you stayed dehydrated for. By the way, don't do that. Increased risk of blood clots. But sometimes you got to get with that blood doctor and see, do I have some specific factor that I was either born with or acquired that is making these clots higher risk in me? Dr. Randy Adair is an amazing internal medicine physician out of Albuquerque who's just done worldwide things with blood clots. He worked with the UNM Cancer Center for years, and he really has a focus in thrombosis, which is blood clotting. And talk about an expert. I think he came down and did some consulting for some facilities here in Carlsbad at one point. He has always been a resource for me. So thank you, Dr. Adair, for fighting the good fight worldwide, let alone in New Mexico, and even helping here in Carlsbad so that we know how to adequately anticoagulate. That means what drugs should people really be on, treating their blood clots and trying to prevent more from occurring. And again, that is a very complex topic that we can continue to expand on sometime in the future. So I hope I've done a good job of just kind of introducing you to some discussion about DVTs and PEs. That's again, blood clots in our legs and our lungs, so that we're more aware of the potential symptoms, when they can occur, what we can do about it, and some of the advancing technology that we do have available here in Carlsbad that can help treat your problems. Have a great week.